Hello, and welcome to today's session of the EpiVac Pink Book webinar series. We're coming to you from Atlanta, and the title of today's session is Meningococcal Vaccines. My name is Joellen Wolicki, and I'm a nurse educator in the Immunization Services Division, which is part of CDC's National Center for Immunization and Respiratory Diseases, NCIRD. I'll be the monitor for today's session. The learning objectives for today's session are 1. Describe the different forms of immunity. 2. Describe the different types of vaccines. 3. For each vaccine preventable disease, identify those for whom routine immunization is recommended. 4. For each vaccine preventable disease, describe characteristics of the vaccines used to prevent the disease. 5. Describe an emerging immunization issue. 6. Locate resources relevant to current immunization practice. And finally, implement disease detection and prevention health care services such as smoking cessation, weight reduction, diabetes screening, blood pressure screening, and immunization services to prevent health problems and maintain health. Our presenter today is Dr. Andrew Kroger. He is a medical officer in the Immunization Services Division here at NCIRD at CDC. Dr. Kroger will be discussing meningococcal conjugate and meningococcal B vaccines. We'll have a question and answer session following Dr. Kroger's presentation. Continuing Education, or CE, is available only through the CDC ATSDR Training and Continuing Education online system. The web address is shown on your screen. The course number for today's session, the live session, is WC2645-081617. CE credit for today's session expires on September 18th, 2017. Enduring CE is available for those watching the archived recast of this NET conference. The course number for the archived recast is WD2645-081617. Enduring credit will expire on June 1st, 2018. Detailed instructions outlining the steps for acquiring CE are available in the resource pod. Please note, all you need is the course number. A verification code is no longer required. In compliance with continuing education requirements, all presenters must disclose any financial or other associations with the manufacturers of commercial products, suppliers of commercial services, or commercial supporters, as well as the use of unlabeled products or product under investigation. CDC, our planners, contact experts, and their spouses or partners wish to disclose that they have no financial interests or other relationships with manufacturers of commercial products, suppliers of commercial services, or commercial supporters. Planners have reviewed content to ensure there is no bias. Today's presentation will not include any discussion of the unlabeled use of a product or a product under investigational use, with the exception of Dr. Kroger's discussion of both meningococcal vaccines in a manner recommended by the Advisory Committee on Immunization Practices, but not approved by the Food and Drug Administration. CDC does not accept any commercial support. If you have questions that are related to the content of the presentation, please type your question into the Q&A pod located in the lower left-hand portion of your computer screen. We will address as many questions as we can following the presentation. Now, I'd like to turn the program over to Dr. Kroger.
Thank you, Joellen. It is my pleasure to discuss meningococcal disease and meningococcal vaccine. For future reference, this content on the vaccine-preventable disease and the meningococcal conjugate vaccines is discussed beginning on page 231 of the Pink Book, and the serogroup B meningococcal vaccine is discussed on page 7 of the Pink Book supplement posted on January 10th, 2017. Meningococcal disease is an acute, potentially severe illness caused by the bacterium Neisseria meningitidis. Neisseria meningitidis, or meningococcus, is an aerobic gram-negative bacteria. Illness believed to be meningococcal disease was first reported in the 16th century. The first definitive description of the disease was in 1805. The bacterium was first identified in the spinal fluid of patients in 1887. Meningococci are classified by using serologic methods based on the structure of the polysaccharide capsule. 13 antigenically and chemically distinct polysaccharide capsules have been described. Almost all invasive disease is caused by serogroups A, B, C, Y, and W. The relative importance of serogroups depends on geographic location and other factors such as age. Neisseria meningitidis is a leading cause of bacterial meningitis and sepsis in the United States. It can also cause focal disease such as pneumonia and arthritis. Neisseria meningitidis is also a cause of epidemics of meningitis and bacteremia in sub-Saharan Africa. The World Health Organization has estimated that meningococcal disease was the cause of 171,000 deaths worldwide in 2000. Meningococci are transmitted by droplet aerosol or secretions from the nasopharynx of colonized persons. The bacteria attach to and multiply on the mucosal cells of the nasopharynx. In a small proportion, less than 1% of colonized persons, the organism penetrates the mucosal cells and enters the bloodstream. The bacteria spread by way of the blood to many organs. In about 50% of bacteremic persons, the organism crosses the blood-brain barrier into the cerebrospinal fluid and causes a purulent meningitis. An antecedent upper respiratory infection, or URI, may be a contributing factor. The incubation period of meningococcal disease is 3 to 4 days with a range of 2 to 10 days. Symptoms include abrupt onset of fever and meningeal symptoms. In 5 to 20% of patients, sepsis can occur without meningitis. This is called meningococcemia with shock, and hallmarks of this entity are hypotension and rash. The case fatality rate is 10 to 15% for all clinical entities, but it's up to 40% in meningococcemia. Meningitis is the most common presentation of invasive meningococcal infection or meningococcal disease and results from hematogenous dissemination of the organism. Meningeal infection is similar to other forms of acute purulent meningitis with sudden onset of fever, headache, and stiff neck, often accompanied by other symptoms such as nausea, vomiting, photophobia, which is eye sensitivity to light, and altered mental status. Meningococci can be isolated from the blood in up to 75% of persons with meningitis. As mentioned, meningococcemia is defined as bloodstream infection, which may occur with or without meningitis. It is characterized by abrupt onset of fever, gastrointestinal symptoms, abdominal pain, vomiting, diarrhea, and a petechial or purpuric rash, often associated with hypotension, shock, acute adrenal hemorrhage, and multi-organ failure. Less common presentations of meningococcal disease include pneumonia, occurring in 5 to 15% of cases, arthritis occurring in 2%, otitis media in 1%, and epiglottitis in less than 1%. This is the hand of a child with meningococcal sepsis. The child has what's called disseminated intravascular coagulation. This is when sepsis causes tissue damage. Sepsis can lead to clotting, which consumes platelets. This can then lead to internal blood pooling, which reduces the flow of blood to tissues. Because of this, tissue lacks oxygen, necrosis can occur, and that's what you see here. This child in particular is at risk of losing this limb because of the necrosis. This is an adolescent with meningococcal sepsis who will lose the right arm because the tissue is not being oxygenated, secondary to the process I just spoke about with blood clotting. This process can occur rapidly, which is why this is such a scary disease and a scary microbe. A patient can develop mild cold-like symptoms in the morning, and by the afternoon, they need immediate life-saving intensive care treatment. Risk factors for the development of meningococcal disease include deficiencies in the terminal complement component pathway. These are components of the immune system. Another risk factor is taking the drug eculizumab. This is used for paroxysmal nocturnal hematuria or hemolytic uremic syndrome. It's a drug that also negatively affects complement components, so the mechanism is similar to the natural deficiency. Other host risk factors include functional or anatomic asplenia and HIV. Certain genetic factors, such as polymorphisms in the genes for mannose-binding lectin and tumor necrosis factor, may also be risk factors. Household crowding and both active and passive smoking are associated with increased risk. Persons with an antecedent viral infection are also at increased risk. Microbiologists working with Neisseria meningitidis isolates are at increased risk of infection and should be vaccinated. Cases of meningococcal disease, including at least 2 fatal cases, have been reported among microbiologists. These persons worked with Neisseria meningitidis isolates and not with patient specimens. Let's turn to what we've learned through various surveillance systems about the epidemiology of meningococcal disease. This graph shows meningococcal disease incidence in the U.S. from 1996 to 2015 from the National Notifiable Disease Surveillance System. Through this period, we've seen a sustained decline in the incidence of meningococcal disease from 1.3 to 0.12 cases per 100,000 population. As you can see, this decline in incidence began prior to the introduction of quadrivalent meningococcal conjugate vaccine, or MenACWY, and prior to the availability of serogroup B or MenB vaccines. This is the incidence of meningococcal disease from 2006 through 2015, depicted for different age groups by different colored lines. Incidence has decreased among all age groups, including among infants less than 1 year of age, shown in blue, and children 1 year of age, shown in yellow, which are age groups where the incidence has historically been the highest. This pie chart shows the proportion of meningococcal disease cases reported in the U.S. from 2006 through 2015 that were due to each serogroup. During this period, serogroups B, C, and Y each caused roughly 25 to 35% of meningococcal disease cases, while serogroup W caused 7% of cases. Serogroups C, Y, and W caused 73% of all cases of meningococcal disease among persons 11 years of age or older. 60% of disease among children from birth through 5 years of age is caused by serogroup B. So next I will discuss the meningococcal vaccines. And I'll begin with the meningococcal conjugate vaccines. Meningococcal conjugate vaccines are composed of meningococcal polysaccharide, which is conjugated to a protein carrier. These vaccines elicit both T and B cell immunity, the B cell immunity being T cell dependent immunity. And by this, I mean it's B cell immunity that is long lasting because it is supported by T helper cells. 2 meningococcal conjugate vaccines are licensed and available in the United States. These are 2 what are known as 2 single component vaccines. There's Menactra or MenACWY-D, and Menveo, which is MenACWY-CRM. Now, there is a third conjugate vaccine, Menhibrix. However, this is no longer being distributed, and all doses of Menhibrix will expire by mid-September of 2017, so you will not see it on this slide set. Menactra, or MenACWY-D, manufactured by Sanofi Pasteur, was licensed by the FDA in January of 2005. Each dose of vaccine is formulated to contain each of meningococcal A, C, W, and Y polysaccharides conjugated to a diphtheria toxoid protein carrier. MenACWY-D is approved for use in persons 9 months through 55 years of age. It is administered by intramuscular injection. MenACWY-D is supplied as a liquid in a single-dose vial and does not contain a preservative or an adjuvant. Menveo was licensed in February by FDA in February of 2010. It is a lyophilized or freeze-dried serogroup A vaccine that needs to be reconstituted with a liquid diluent containing serogroups C, Y, and W135. We refer to this vaccine as Menacui-CRM or Menacui-CRM for cross-reactive material. This vaccine may be used for any persons 2 months through 55 years of age for whom MenACWY is indicated, including revaccination. It is administered by intramuscular injection. This vaccine requires reconstitution, and reconstitution produces a single dose of vaccine. Limited data suggests that different conjugate vaccine proteins can be used interchangeably. When feasible, the same brand of vaccine should be used for all doses in the series. However, if providers do not know or have available the type of vaccine previously administered, they should use the vaccine that they have to continue or complete the series. In addition to the conjugate vaccines, there is a quadrivalent vaccine that is pure polysaccharide vaccine called Menimune. This vaccine was not known to have a long duration of immunity, so its recommendation really was restricted for individuals in high-risk groups. Because of limited utility, the manufacturer is discontinuing production of Menimune, and the last remaining lots will expire June through September 2017. Because Menimune is the only meningococcal vaccine licensed for persons, meningococcal conjugate vaccine licensed for persons 56 years old or older, the meningococcal work group provided the following updated guidance in February 2017 to address supply. Persons older than 55 years of age who are recommended for meningococcal vaccine should receive the conjugate vaccine. This, of course, will include meningococcal vaccine naive persons older than 55 years who anticipate requiring only a single dose of meningococcal vaccine. This can be includes usually travelers, persons at risk in an outbreak. And don't forget that persons who have been vaccinated previously with MenACWY, the conjugate product, or who are high risk, like persons with asplenia, HIV, microbiologists, they've been recommended for the conjugate vaccine at age 56 years and older, in preference to the polysaccharide vaccine since the 2013 recommendation. So that stays the same, of course. It's an off-label recommendation. I'd now like to discuss the routine MenACWY vaccine recommendations for adolescents. Meningococcal conjugate ACWY vaccines are listed on the 2017 Child and Adolescent Immunization Schedule as outlined in red here. It's listed for high-risk children beginning at 2 months of age and for routine vaccination at 11 through 12 years of age, with a booster dose at 16 to 18 years of age. So to talk about the routine recommendations, ACIP recommends routine vaccination with either MenACWY vaccine at 11 or 12 years of age, with a booster dose at 16 years of age. For adolescents who receive the first dose at 13 through 15 years of age, a one-time booster should be administered, preferably at age 16 through 18 years. Although 2 doses of MenACWY can be described as having a minimum interval of 8 weeks, it is preferable to use a longer interval between doses, 3 to 5 years if possible, and we want that second dose of vaccine to be given after the 16th birthday. Back in 2005, when MenACWY was first recommended, it was recommended for a single dose pending the availability of additional data. Follow-up serologic data demonstrated that there was a decline in antibody levels 3 to 5 years after the first dose, although few breakthrough cases were reported as a result of this decline. But recognizing the reality of waning led to ACIP discussions about 2 doses of this vaccine for healthy adolescents, and ACIP changed their recommendation based on the ages at which there is risk for disease. This graph from the CDC's active bacterial core surveillance system shows the rates of meningococcal serogroup C and Y. C is in blue, Y is in green, by single year of age through 25 years between 1999 through 2008. Note that there is an increase in the rates for both serogroups at ages 17 through 21 years of age. So we know from vaccine effectiveness studies that we have waning, and many adolescents are not protected 5 years after vaccination. So this is why ACIP concluded that a single dose of meningococcal conjugate vaccine administered at age 11 or 12 years is unlikely to protect most adolescents through the period of increased risk at ages 16 through 21 years. On the basis of this information, in 2010, ACIP recommended maintaining the recommended dose at age 11 years and adding the booster dose at age 16 years. So healthy persons who receive their first routine dose of meningococcal conjugate vaccine at or after age 16 years, they do not need a booster dose unless they develop a high-risk condition. Routine vaccination of healthy persons who are not at increased risk for exposure to Neisseria meningitidis is not recommended after age 21 years because the risk has gone down. So booster doses are not recommended for 22 years of age and older. Even if that first dose was administered at 11 through 15 years of age, these data indicate that the risk of disease drops after this age for healthy persons. So now I'd like to discuss MenACWY vaccine recommendations for persons at increased risk for meningococcal disease, and I'll explore some of these risk factors individually, and I combine a few others. Persons with functional or anatomic asplenia or HIV infection are recommended for meningococcal conjugate vaccine. The term functional asplenia includes persons with sickle cell disease. For patients younger than 19 months of age, a 4-dose series of Menacui-Creme is recommended at 2, 4, 6, and 12 to 15 months. For persons 19 through 23 months of age who have not received a complete series of vaccine, a 2-dose primary series of Menacui-Creme is recommended with 12 weeks or more between the doses, although this series will be valid if the doses are separated by at least 8 weeks. Notice that Menacui-D, Menactra, is not recommended for children with functional or anatomic asplenia or HIV through 23 months of age. This is because children in this age group are recommended for DTaP and PCV13 vaccination as well. These vaccines interfere with Menactra, and children with asplenia and HIV are at high risk for meningococcal disease and pneumococcal disease, so we don't want this interference occurring. So there is interference by Menactra on PCV13. If a person has functional or anatomic asplenia and receives Menactra and PCV13 simultaneously or less than 4 weeks apart, the dose of PCV13 should be repeated and should be given 4 weeks after whichever of the two vaccines were administered most recently. Children with functional or anatomic asplenia, HIV, or any other meningococcal risk factor are at risk for meningococcal disease, and there is interference by DTaP on Menactra. If a person's indicated for both DTaP and Menactra by virtue of any medical risk factor, complement component deficiency, functional or anatomic asplenia, or HIV, they should either be administered simultaneously or Menactra should be administered first. If DTaP is administered first, providers should wait 6 months before administration of Menactra. However, if this interval is violated, there's no recommendation to repeat any doses. So because of all of this, go back to your second bullet, children younger than 23 months of age, the choice of available vaccine is Menveo, because for Menveo, none of this is an issue. It's really Menactra for which you have to follow these spacing rules. Children 24 months or older who have not received a complete series should receive a complete series of either MenACWY vaccine, either CREM or D, 8 to 12 weeks apart. Children with persistent complement component deficiency, they're at risk of invasive meningococcal disease. For children 2 through 18 months of age, they can receive the 4-dose series of Menacwi CREM, as I mentioned, the same schedule on the previous slide for the other group. Menacwi D is licensed beginning at 9 months of age, and children with persistent complement component deficiency can receive this vaccine at this younger age group. We don't have concerns about interference with PCV13 like we do with HIV or functional anatomic asplenia. And so Menacwi D could in fact be licensed at 9 months of age, so they could receive a 2-dose series of this vaccine with a 12-week interval and an 8-week minimum. And that would begin at 9 months of age. Children 19 months of age and older without a complete series of Hib-Menvy or Menacwi should receive a 2-dose primary series of MenACWY-D or MenACWY CREM. So remember that there are spacing rules that apply for DTaP vaccine in children with persistent complement component deficiency, HIV, or anatomic asplenia that are specific to Menactra. Continuing with high-risk discussions, persons 2 through 55 years of age who have non-medical risk factors for meningococcal disease include first-year college students younger than or equal to 21 years of age living in residential housing, or travelers to areas where meningococcal disease is hyperendemic or epidemic, microbiologists routinely exposed to isolates of Neisseria meningitidis, or military recruits. These patients should receive 1 dose of MenACWY. MenACWY is recommended for control of meningococcal outbreaks caused by vaccine-preventable serogroups A, C, W, and Y. An outbreak is defined by the occurrence of at least 3 confirmed or probable primary cases of the same serogroup of meningococcal disease during a period of 3 months or less, with a resulting primary attack rate of 10 or more cases per 100,000 population. Sorry about that. Children who receive primary immunization and remain at increased risk should receive booster doses. If the primary immunization is complete by 7 years of age, the first booster should be 3 years after the primary immunization and every 5 years thereafter if at continued risk. If primary immunization is complete on or after 7 years of age, the first booster should be 5 years after primary immunization and every 5 years thereafter if at continued risk. ACIP also recommended in 2009 routine revaccination of certain persons at non-medical high risk of exposure. These groups include microbiologists with prolonged exposure to Neisseria meningitidis and frequent travelers to or persons living in areas with high rates of meningococcal disease, such as sub-Saharan Africa or traveling to the Hajj in Saudi Arabia. These persons should be revaccinated every 5 years as long as they remain at increased risk. Meningococcal conjugate vaccine should be administered for persons 2 through 55 years of age. For persons 56 years of age and older who were vaccinated previously with MenACWY and are recommended for revaccination, or for whom multiple doses are anticipated, for example, asplenia or microbiologists, I'll repeat that MenACWY is preferred, and fairly soon we'll also be, recommending. I mean, it is recommended because MenImmune is being phased out, that these persons should receive the conjugate vaccine as well. International travelers should receive a booster dose of MenACWY if the last dose was administered 5 or more years previously. Note that vaccination with MenACWY or MPSV4 in the 3 years before the date of travel is required by the government of Saudi Arabia for all travelers to Mecca during the annual Hajj. Post-licensure data from the Vaccine Adverse Events Reporting System, or VAERS, demonstrate the most frequently reported adverse events for meningococcal vaccines include local reactions for 1 to 2 days. The range for local reactions for MenACWY is 11 to 59%. For Menactra in adolescents and adults, this includes injection site erythema in 14.6% and injection site pain in 60%. For Menveo in adolescents and adults, this includes injection site erythema in 19.7% and injection site swelling in 13.7%. Low-grade fever occurs in 5 to 17% of recipients of MenACWY. For Menactra in adolescents and adults, this includes fever occurring in 16.8%. Systemic reactions occur in 4 to 54%. For Menactra in adolescents and adults, this includes dizziness in 13.4% and syncope in 10%. Of all reported events for Menactra in adolescents and adults, 6.6% were coded as serious. That is, they resulted in death, life-threatening illness, hospitalization, prolongation of hospitalization, or permanent disability. Serious events included headache, fever, vomiting, or nausea. The higher estimates for local and systemic reactions on the slide come from pre-licensure studies cited in the vaccine package insert. For Menveo, syncope occurred in 8.8% of reports. There was no pattern among serious adverse event reports for either vaccine, including a few reported deaths. Rates of local and systemic adverse events observed after administration of Hib-Menc-Y, which is not on this slide, was comparable to rates observed after administration of Hib. Therefore, was found to be safe and immunogenic for both Hib and meningococcal serogroups C and Y. But as mentioned, this vaccine will reach its outdate, no more unexpired vaccine by September 16th. I'm now going to discuss serogroup B meningococcal or MenB vaccine recommendations. There are 2 recombinant serogroup B meningococcal or MenB vaccines licensed in the United States. MenB FHBP or Trememba is manufactured by Pfizer and was licensed by the FDA in October 2014. MenB4C or Bexsero is manufactured by GlaxoSmithKline and licensed by the FDA in January of 2015. Both are licensed for persons aged 10 through 25 years of age. Trememba is recommended to be used as a 3-dose series administered at 0, 1 to 2, and 6 months, or a 2-dose series administered at 0 and 6 months. We'll discuss this consideration for determining which of these 2 schedules to use on a later slide. Bexsero is recommended as a 2-dose series at 0 and 1 through 6 months. MenB should be administered as either a 2-dose series of Bexsero or a MenB4C, or a 2 or 3-dose series of Trememba and FHBP. These 2 vaccine products are not interchangeable. The same vaccine product should be used for all doses in the series. Based on available data and expert opinion, MenB4C and MenB FHBP may be administered concomitantly with other vaccines indicated for this age, but at a different anatomic site if feasible. Different anatomic site means more than 1 inch from another dose of vaccine. The ACIP has not stated a preference for the use of one MenB vaccine over the other. There are 2 kinds of recommendations for meningococcal B vaccine use. There is a recommendation for use in individuals 10 years of age and older at increased risk of disease, and there is a recommended for use in adolescents and young adults not at increased risk for disease. Bexsero or Trememba should be administered to certain persons 10 years of age and older who are at risk of meningococcal disease. These include persons with persistent complement component deficiencies, which includes persons taking the drug eculizumab. This impairs, as mentioned, it impairs complement function. Persons with anatomic or functional asplenia, which includes sickle cell disease, microbiologists who are routinely exposed to isolates of Neisseria meningitidis, and persons identified to be at increased risk because of a serogroup B meningococcal disease outbreak. Use in persons over the age of 25 years is recommended by ACIP for high-risk groups. Note this is an off-label ACIP recommendation. This is considered, all of this is considered a Category A recommendation, meaning this recommendation is applied to persons with one of the listed high-risk conditions with the full weight of the recommendation. Of note, certain other groups are not included in this recommendation, including persons who are included in the conjugate vaccine recommendations. So note that MenB vaccination is not recommended for children 2 months through 9 years of age, whether they're high risk or not. Persons who travel to or reside in countries where meningococcal disease is hyperendemic or epidemic because of outbreaks in these regions are not generally caused by serogroup B, and routine use in first-year college students living in residence halls, military recruits, or all adolescents for that matter. I'm going to now kind of quickly discuss Trememba. Regarding Trememba, whether a 2 or 3 dose series should be administered depends on the indication for vaccination. For persons at increased risk for meningococcal disease and for use during serogroup B outbreaks, 3 doses of MenB FHBP should be administered at 0, 1 to 2, and 6 months. When given to healthy adolescents who are not at increased for meningococcal disease, 2 doses of MenB FHBP should be administered at 0 and 6 months. If a healthy adolescent has already received 2 doses of Trememba and they were not separated by a 6-month interval, a 3rd dose should be scheduled 4 months after the 2nd dose. However, if minimum intervals are violated and 3 doses have already been administered, There's no recommendation for a fourth dose of the same brand of vaccine, regardless of whether the child is a 3-dose eligible or a 2-dose eligible child. So I've kind of discussed, with respect to Trememba, use in healthy adolescents. So now let me kind of cover this more generally. We do have a recommendation for MenB vaccine. We call it a permissive recommendation. It may be administered to adolescents and young adults 16 through 23 years of age to provide short-term protection against most strains of serogroup B meningococcal disease. The preferred age for MenB vaccination is 16 through 18 years of age. This is considered a Category B recommendation. Vaccine providers should discuss the benefits and risks of administering the vaccine with the patient and family to determine if the vaccine should be administered. I'll now discuss meningococcal vaccine contraindications and precautions. So, vaccine with meningococcal vaccines is contraindicated for persons known to have had a severe allergic or anaphylactic reaction to a vaccine component, including diphtheria toxoid, or to a prior dose of that specific vaccine. A precaution for meningococcal vaccine is moderate or severe acute illness. Vaccine should be deferred for persons until the condition has improved. However, for mild